Okay, good morning, everyone. Again, a bright Sunday, and we are here to discuss very important two landmark trials or studies in palliative care. And this will be presented by none other than TMH, uh, oldest hospital which started MD Palliative Medicine, first hospital. And now this will be first. This presenter will be Dr. Shruti Kamble, who is second year MD Palliative Medicine student at Palliative Medicine, Tata Memorial Hospital, Mumbai. Shruti's area of interest are management of palliative care emergencies and pediatric palliative care. This will be moderated by Dr. Prasun. We have heard Prasun many times. Prasun was again a MD students of Tata Memorial Hospital, but he has grown now and he has become consultant at Actract Mumbai. Uh, he got distinction in MD Palliative Medicine and he is recipient of late Dr. Narayanan Bisaria Gold Medal Award and Dr. P.R. Bhanderkar Award in Surgery and Gold Medal in Pharmacology. I think he is a very brilliant student. He was a brilliant student. Definitely he is extraordinary super consultant also must be and doing extraordinary work at this hospital. He is member of multiple societies, and every resident of palliative medicine should join as many as societies as possible related to oncology and palliative medicine. And this is again a role modeling work what Prasun is doing for other juniors. Uh, Prasun, we are very happy and everybody is looking forward that what are the two important landmarks and trials you have brought with Shruti. So go ahead. And today, this work was actually Dr. Joyita would have done, but she's not feeling well. So I have introduced and have taken over this work from Dr. Joyita. Thank you very much, Shruti. You can start. If whether Prasun has joined.
Yes, ma'am, I have joined.
Okay, okay, good. Please go ahead.
Start my screen share. Are my slides visible?
Slides are
not yet on full screen.
Slideshow you have.
Is it on full screen now?
Yeah.
Yes. Okay. Okay. So just a little bit, I wanted to talk about this topic in itself, the title of today's topic, which is landmark studies. So initially, whenever we had journal clubs, this term landmark was never really frequently used. So my research for today's seminar started with looking up what exactly landmark studies meant, which made me realize that landmark clinical trials are something that are practice changing and highly influential studies that cause a shift in the medical practice, and they clarify certain previously unclear answers to critical questions in the medical management. And certain peculiarities about these landmark studies are that they have long-term relevance in the medical community. They're frequently cited in academic texts and guidelines, and they have challenged the conventional medical management, leading to a change in practice, and hence they are practice changing. So the flow of today's presentation will include the background and rationale, aims and objectives, methodology, results, discussion, and conclusion. And I've also added the consort checklist after the two papers. So coming to the first paper that I'd like to discuss today, this is early palliative care for patients with metastatic non-small cell lung cancer. This was done by the primary investigator Tamil, and it was published in the New England Journal of Medicine in 2010. So starting from the background, metastatic non-small cell lung cancer is the leading cause of death from cancer worldwide. And it is a debilitating disease that results in a high burden of symptoms and poor quality of life. The estimated prognosis after diagnosis is less than a year. Previously conducted studies have found out that introducing palliative care shortly after after diagnosis was feasible and acceptable among outpatients with metastatic non-small cell lung cancer. But traditionally, palliative care has been delivered late in the course of the disease to patients who are hospitalized and already in inpatients, or only as a consultative service for patients with uncontrolled symptoms. Previous studies have also showed that late referrals to palliative care are inadequate to alter the quality and delivery of care provided to patients with cancer. And to truly have a meaningful effect on a patient's quality of life and end of life care, palliative care services must be provided earlier in the course of the disease. With this in mind, the aim of this study was to examine the effect of early palliative care integrated with standard oncological care on patient reported outcomes, the use of health services, and the quality of end of life care among patients with metastatic non small cell lung cancer. The primary objective was to assess the impact of early integration on quality of life with advanced non small cell lung cancer. The secondary objective was to assess the impact of early integration with palliative care on mood and illness and understanding of disease, amongst the others. The hypothesis was that patients who received early palliative care in ambulatory care setting as compared to patients who received standard oncological care would have a better quality of life, lower rates of depressive symptoms, and less aggressive end of life care. The study design was a randomized controlled trial. It was conducted at a single center at Massachusetts General Hospital at Boston in the Thoracic Oncology Clinic. It was a phase 3 trial, and the allocation to the intervention groups was parallel. It was conducted from a period of 2006 to 2009, and the population included patients who were diagnosed with metastatic NSCLC within the previous 8 weeks, having a performance score on the ECOG of 0, 1, or 2. The randomization and masking was 1:1 without stratification, and this was a non-blinded study. The inclusion criteria: patients with histologically or cytologically confirmed incurable NSCLC with stage 3B with a pleural or pericardial effusion or stage 4 disease, performance status of 0 to 2 on ECOG, diagnosis of an advanced disease within the previous 8 weeks, ability to read and respond to questions in English, and permission of the attending physician was required. The exclusion criteria had prior chemotherapy for a metastatic disease or existence of other comorbid disease, which, in the opinion of the investigator, prohibited the participation in the protocol. So this was the flowchart of the way this study would be conducted. That is, incurable NSCLC patients who were diagnosed within 8 weeks would complete a baseline questionnaire before being allocated to their individual arms. The questionnaires would be on the quality of life, the mood, the illness understanding, and also caregivers would be completing a questionnaire on fam care, mood, illness understanding, and then they would be randomized into the integrated palliative care arm or the standard palliative care arm. Thereafter, after they complete the questionnaires, again at 12 weeks, 18 weeks, and 24 weeks, they would again undergo the questionnaire, and as with the caregivers. So in this integrated palliative care intervention, what did this intervention include? So it included 5 main domains. That was illness understanding and education regarding their disease, symptom management pertaining to pain, pulmonary symptoms such as cough, breathlessness, fatigue, sleep disturbance, disturbances in mood, having anxiety or depression, gastrointestinal symptoms, decision making, that is to inquire about the mode of decision making, any assistance with treatment in decision making, if necessary, would be provided. Coping with life-threatening illness. How are these patients and caregivers coping with the diagnosis? Referrals and prescription that involved identification of a care plan for future appointments, and referrals to other care providers if needed. The standard palliative care would be provided to both arms, and patients who are randomized to the standard palliative care would also be seen by the palliative care team at the request of the treating oncologist or by the patients or their families. And none of the participants were denied the opportunity to meet with the palliative care team at any time. When the participants on the standard arm meet with the palliative care, the care would not be standardized. And this study anticipates that palliative care team will follow and treat these patients as they would any other patient receiving palliative care. Patients on this arm who experience distress related to completing the questionnaires will be referred to their primary oncologist for counseling. The patient-reported measures were quantified using the health-related quality of life, the FACT tool, that is the Functional Assessment of Cancer Therapy Lung Scale, which includes physical, functional, emotional, and social well-being domains. For symptoms specific to lung cancer subscale of the FACT scale would be used. The trial outcome index, which is the sum of scores of the lung cancer subscale, and the physical well-being and functional well-being subscales on the FACT scale would be used. And we would primarily be measuring the change from the baseline to 12 weeks after initiating the palliative care consultation. For assessment of mood symptoms, the hospital anxiety and depression scale and the patient healthcare questionnaire 9 would be used. For measures of healthcare use, a lot of data was retrieved from the electronic medical records relating to the anti-cancer therapy, medication prescriptions, referral to hospice, admissions, emergency department visits, the date and location of death. The data was collected at the baseline and at follow-up assessments at 12 weeks. The participants who had no scheduled clinic visits within this period received questionnaires by mail. And when the responses were incomplete, the research staff documented the reasons for which the participant did not give a full response. The primary outcome would be the change in score on the trial outcome index from baseline to 12 weeks. So for the statistical analysis, descriptive statistics were used to estimate the frequencies, means, and standard deviation of the study variables. The differences between study groups in baseline characteristics and clinical outcomes were assessed with the use of two-sided Fisher exact test and chi-square test for categorical variables and independent sample student t-test for continuous variables. A multivariate linear regression analysis adjusted for baseline scores was used to examine the effect of the intervention on the quality of life outcome. Intention to treat analysis was used. The survival time was calculated with the use of Kaplan-Meier method. And a Cox proportional hazards model was used to assess the effect of the intervention on survival with adjustment for demographic characteristics and baseline ECOG. So coming to the results, the baseline characteristics of the two groups were more or less the same. But here we can see that the proportion of white subpopulation was more in this study. Also, all these patients were receiving some sort of treatment for their cancer, which included majority patients were on platinum-based combination therapy. And otherwise, the baseline characteristics were the same. Coming to the quality of life measures, on the FACT scale, the standard and early palliative care had a similar score, and the same was for the lung cancer subscale and the trial outcome index. So just a little bit information about these scales. So the functional assessment of cancer therapy lung is a scale which scores from 0 to 136, and higher scores would indicate better quality of life. The lung cancer subscale of the FACT scale, which scores it ranges from 0 to 28, with higher scores indicating fewer symptoms. And the trial outcome index is the sum of the scores of the lung cancer subscale and the physical well-being and functional well-being subscales on the FACT scale. So coming to the actual results, the palliative care visits, the patients who were assigned to the early palliative care, except for one patient who died within 2 weeks after enrollment, had at least one visit with the palliative service by the end of the 12th week. The average number of visits in the palliative care group was 4, and 10 patients who were already on the standard care had a palliative care consultation in the 12 weeks of the study to address symptom management. The patients in the palliative group had a 2.3 point increase in the mean trial outcome index score from baseline to 12 weeks, as compared to a 2.3 point decrease in the standard care group. Coming to the change, the percentage of patients with depression at 12 weeks, as measured by the hospital anxiety depression scale and the patient healthcare questionnaire 9, was significantly lower in the palliative group than in the standard care group, although the proportion of patients receiving new prescriptions for antidepressant drugs was similar in the two groups. The percentage of patients with elevated scores for symptoms of anxiety did not significantly differ between the groups. At the time of analysis of end of patients had died, and the median duration was 7 months. Within this subsample, a greater percentage of patients in the group assigned to standard care than in the group assigned to early palliative care received aggressive end-of-life care. Fewer patients in the standard care group than in the palliative group had resuscitation preferences, which were documented in the outpatient electronic records. This study did not have adequate power to examine the specific indicators of aggressive care at the end of life. Despite receiving less aggressive end of life care, the patients in the palliative care group had significantly longer survival than those in the standard care group. There was a significant between group difference in the mean change in the scores from baseline to 12 on the factorial scale. There was no difference found in the mean change in the scores on the between group difference was found in the scores on the trial outcome index. At 12 weeks, there was a significant difference, as we can see in this diagram, in the HADS depression subscale and in the PHQ-9, but there was not a significant difference found in the anxiety subscale. Here we can see in the Kaplan-Meier diagram, like we discussed earlier, that the patients in the early palliative group had a 2-month survival longer than the ones who were on standard care alone. So this study shows that the effect of palliative care when provided throughout the continuum of care for advanced lung cancer, it resulted in a survival that was prolonged by approximately 2 months and clinically meaningful improvements in the quality of life and mood. Moreover, this care model resulted in a greater documentation of resuscitation preferences in the outpatient electronic medical record, as well as less aggressive at the end of life, less aggressive care at the end of life. Despite similar cancer therapies in our two study groups, the patients assigned to early palliative care had an improved quality of life as compared to those receiving standard care alone. The rates of depression also differ significantly between the groups, with approximately half as many patients in the palliative care group as in the standard group reporting clinically significant depressive symptoms on the hospital anxiety depression scale. And this effect was not due to a between group difference in the use of antidepressant agents. To date, the evidence supporting the benefit of palliative care is sparse, and most studies have notable methodological weaknesses, especially with respect to the quality of life outcomes. This study shows that early outpatient palliative care service for patients with advanced cancer can alter the use of healthcare service, including care at end of life. Other studies of outpatient palliative care have failed either to investigate these outcomes or to show an effect on the use of resources. In this trial, significantly more patients in the group assigned to early palliative care than in the standard care group have the resuscitation preferences documented. And this is a very essential step in clarifying and ensuring the respect for patients' wishes about their care at the end of life. This intervention also led to less aggressive end of life care, including reduced chemotherapy and longer hospice care. Given the trends toward the aggressive and costly care at the end of life among patients with cancer, timely introduction of palliative care may serve to mitigate, to decrease the unnecessary and burdensome personal and societal costs. Coming to the strengths of the study, investigators have often relied on referrals to palliative care instead of using a recruitment approach designed to obtain a representative sample. Because all patients with a new diagnosis of metastatic non-small cell lung cancer were eligible for enrollment in this study, the generalizability of this finding, of the findings of this study were expanded. There was a loss to follow-up and high percentage of participants who completed this, that the feasibility and acceptability of early palliative care would be something that is doable. Finally, the trial was adequately powered to detect the changes in both quality of life and mood. and we prospectively collected the data on the end-of-life care. Coming to the limitations, the first most important limitation was that this study was conducted at a single tertiary care site with a specialized group of thoracic oncology providers and palliative care clinicians, thereby limiting the generalization of results to other care settings or patients with other types of cancer. The study sample lacked diversity with respect to race and ethnic group, like I mentioned, how there was a majority of white population, due to which we are unable to assess the effect of these factors on the study outcomes. Even though there was use of a randomized control design, this was the patients and the clinicians were aware of the study assignments. That is, this was a non-blinded study. In addition, the patients who were on standard care were also allowed to consult with the palliative care team and carrying the last observation forward for all the missing data in the intention to treat analysis is a conservative approach. Therefore, the actual treatment effect would actually be greater than the one which is reported. Coming to the conclusion, early integration of palliative care for patients with metastatic NSCLC is a clinically meaningful and feasible care model that has effects on survival and quality of life that are similar to the effects of the first-line chemotherapy in such patients. As compared with the study participants who received standard care, those who were assigned to early palliative care had an improved mood, more frequent documentation of resuscitation preferences, and less aggressive end-of-life care. And although these findings must be replicated in a variety of care settings and cancer populations, these results offer great promise for alleviating distress in patients with metastatic disease and addressing the critical concerns regarding the use of healthcare service at the end of life. So this study is actually done in accordance to the consort checklist. So just because in the benefit and interest of time, I'd be just rushing through this. So I'll start with the second study for today's seminar. So the other paper that I'd like to discuss today is efficacy of oral risperidone, haloperidol, or placebo for symptoms of delirium among patients in palliative care, a randomized clinical trial. The primary investigator was Meera Agar. This was published in the Journal of American Medical Association Internal Medicine in 2017. And with a minor correction, it was republished in January 2017. So the background, delirium is a highly prevalent condition in patients receiving palliative care, with up to 4 in 10 people having delirium on admission to a palliative care unit. And as we approach end of life, there are higher rates of delirium. The management primarily comprises of treating the reversible causes using pharmacological and non-pharmacological interventions with the goals which should be aligned to reduce distress, maintain safety, and resolve delirium. Traditionally, antipsychotics have been considered by most clinicians as the first-line agents for delirium, despite limited level 2 evidence for management of delirium in any healthcare setting, including the palliative care setting. And there has been no systematic evaluation of toxicity profile in relation to delirium management with typical or atypical antipsychotics, in particular the extrapyramidal toxicity and degree of sedation. So by now, we already know that the randomized clinical trials of antipsychotic drugs for managing established delirium has been suggested that there is a potential to improve the overall delirium severity. However, whatever has been done till now has had some sort of shortcomings. So they had a flawed concealment of allocation, certain studies were inadequately powered, and 3 studies were placebo controlled. And only these 2 out of these 3 studies which are placebo controlled, it was conducted in the ICU setting with critically ill patients. And this study found out that there was no significant difference in the number of delirium-free days despite the use of antipsychotics. So the current practice for pharmacological management of delirium is limited only to antipsychotics, and most commonly used drug is haloperidol, with little empirical evidence of its efficacy. There's also sparse outcome data for this medication in treatment of delirium, although there are clinical practice guidelines suggesting that it may be of some use. Risperidone similarly has already been used in the clinical setting with similar limitations and has the potential of equal efficacy, but lower incidence of toxicities, that is extrapyramidal side effects associated with the typical antipsychotics, that is the first drug haloperidol. Risperidone is currently not approved for use for this indication despite the current clinical use. And because of all this gray area, there is a need for randomized controlled trial evidence of the efficacy of antipsychotics to control targeted delirium symptoms and also to consider the broader implications on caregiver and patient distress. The primary aim was to improve the pharmacological management of delirium in patients who are under the palliative care setting. The primary objective is to compare the efficacy of oral risperidone solution and control. The control would be an oral placebo solution with subcutaneous midazolam rescue as needed. The secondary objective is to compare the efficacy of oral haloperidol solution and control in a control of targeted delirium symptoms at 72 hours from the treatment commencement. The other secondary objective is to compare the efficacy of oral haloperidol solution and oral risperidone solution and to describe the profile of delirium in the treatment arms, giving the delirium duration, severity, subtype, and cognitive impairment and resolution. These are the other secondary objectives as mentioned in the protocol. The null hypothesis is that there is no difference in the change of sum of scores on the nursing delirium scores between the oral risperidone and oral placebo, and secondary, no difference between haloperidol and placebo. And third null hypothesis that there is no difference between risperidone and haloperidol at 72 hours from treatment commencement. This null hypothesis would be rejected if the p-value is less than 0.05. So this design was also a randomized control trial, which is an interventional study, which was conducted at 11 different hospice and palliative care services, which is conducted by the Australian National Palliative Care Clinical Studies Collaborative. This was a double-blinded study, and the intervention to assignment was parallel. This was a phase 3 study. The purpose of this study was the treatment. And the population which was included was palliative care in patients with incident or prevalent delirium. And this was defined by the DSM-4R criteria for delirium or memorial delirium assessment score of more than equal to 7. The study was conducted throughout a period from August 2008 to April 2014, and they received funding from the Government National Palliative Care Program of Australia. So the random number tables were used at an independent blinded central registry for site randomization, and the participants were randomized in blocks of 6 by site in a 1:1:1 ratio by arm. And allocation concealment was ensured by sealed opaque envelopes. The treatment assignment was double-blinded. That is, the participants and investigators were masked to the treatment group for duration of the study. So patients who were included were the ones who, like I mentioned previously, had diagnosis of delirium based on the DSM-4 criteria. The score of the nursing delirium scale, items 2, that is inappropriate behavior, and or item 3, that is inappropriate communication, and or item 4 of illusions and hallucinations. So there would be more than equal to one item. And the nursing delirium score actually has 4 features, that is disorientation, inappropriate behavior, inappropriate communication, illusion, hallucination, and psychomotor retardation. But according to the investigators, they thought that the most distressing symptom would be number 2, 3, and 4. And that's why they've disregarded having disorientation and psychomotor retardation in the inclusion criteria. The other assessment tool that they've used is the memorial delirium assessment scale. The exclusion criteria, patients who had delirium due to alcohol or other withdrawal syndrome, where more specific treatment would be indicated, would not be included in the study. Current or past history of neuroleptic malignant syndrome, regular antipsychotic use within the past 48 hours. But if these patients required an as-needed required dose of haloperidol, chlorpromazine, or levomethomazine is allowed if it was administered more than 24 hours previously. The dose was at or below the study dose for the age group prescribed for a non-delirium indication. Maintenance of an antipsychotic required for other diagnosis, previous adverse reaction to the study medication, and established Parkinson's disease or other EPS disorder. Documentation of prolonged QT syndrome. Clinician predicted survival of less than 7 days. A CVA in the last month. Seizures within the last month. Pregnant or breastfeeding patients. So the flow would be that patients who are 65 years or younger receive 0.5 mg of loading dose of risperidone or haloperidol administered with the first dose of 0.5 mg and then 0.5 mg maintenance dose at every 12 hours till 72 hours. The doses could be titrated by 0.25 mg on day 1 and by 0.5 mg thereafter to a maximum dose of 4 milligrams per day. For participants who are older than 65 years, the loading, initial and maximum doses were halved. The placebo solution was titrated similarly using matching volumes of solution for each dose level. The doses will be increased if the sum on the nursing delirium score scale for items 2, 3, and 4 was 1 or more at the most recent assessment, which was conducted at every 8 hours by the nurses. The dose reduction with the prior dose could also occur for adverse effects. Resolution of delirium, that would be if the MDAS score would be less than 7 for 48 hours, or resolution of all symptoms, that is having a UDAS score of less than 1 for 48 hours. The study treatment duration was 72 hours, with the last assessment performed 12 hours after the sixth dose. All patients received individualized treatment plans, including treatment of reversible precipitants where clinically indicated and non-pharmacological measures. The protocol also defined an as-needed subcutaneous midazolam injection, that is 2.5 mg, and this would be available when the participant scored 2 on the new desk item for inappropriate behavior or illusions or hallucinations and were deemed to immediate interventions for safety or distress, and this could be repeated every 2 hours. Intravenous benztropine mesylate 1 to 2 mg was also available for serious EPS. Participants were observed daily with NUDES scores measured every 8 hours by trained nurses and MDAS scores. Use of rescue midazolam, adverse effects, and vital status were assessed daily. The study drug was discontinued if adverse effects became unacceptable. The treating clinician deemed this treatment ineffective or at the onset of dysphagia. Maintenance of blinded study medication was optional for an additional 48 hours if the partial response occurred or to taper the dose with resolution of symptoms. Sorry. The primary outcome was the change in sum of scores, and it would be measured on the nursing delirium screening scale, items 2, 3, and 4. The secondary outcomes are many as mentioned in the protocol. So this is the flow of the study. So palliative care inpatients were screened and consent was taken on delirium development. Those with incident and prevalent delirium were randomized into the 3 arms. That would be the risperidone solution and rescue protocol, which was midazolam, the haloperidol arm, and the placebo arm. After 72 hours, the safety and efficacy assessments would be done. And after that, there would be exit from the study and follow-up would be done at 3 weeks by telephone and 1 visit at 1 month. So there were no agreed upon primary outcome measures for assessing the changes in symptoms of delirium associated with distress, and nor were there any agreed upon minimally important clinical difference for the measuring the improvement. Intention to treat analysis was used. The change in sum of scores was done by the group effect from the regression of average of the follow-up scores. For any missing values, multiple imputation was done. For toxicity, each patient was analyzed using the random effects mix modeling. Survival analysis was done by using a Cox regressional frailty model. The time to event analysis was also done by using the fine and Gray's method, and the power and sample size, a total sample size of 110 patients will provide 80% power to detect a difference of the change of the NUDES score of 1 unit, assuming a baseline standard deviation of 1.92 units and a correlation of at least 50% between the baseline and follow-up scores. Sorry that I'm really speeding up through all this, but coming to the results, 1,819 patients were referred to the study, out of which 306 were assessed for eligibility. 57 participants were excluded because they declined. Certain participants declined to participate, and certain did not meet the inclusion criteria. Out of this, 249 patients were randomized, and 82 were included in the risperidone arm, 81 were included in the haloperidol, and 86 were the ones who were randomized to receive placebo. And from this, 46 are the ones who, 47 patients completed the risperidone regimen, 61 completed the haloperidol regimen, and only 64 completed the placebo regimen. Coming to the baseline characteristics, the mean scores of delirium at baseline throughout the three arms were the same. Also, the age throughout the three arms for was more or less the same. That is, they all were more than 70 years. Here we can say in the age less than 65-year group, in the haloperidol arm, there were only 8 participants as compared to 18 and 17 participants in the risperidone and placebo arm, respectively. The performance status on the Australian Karnofsky performance score was also the same. Here we can also see that the median opioid dosage in the haloperidol arm was 33 milligrams. So coming to the analysis, here we can see on the right in the secondary multivariable mixed model analysis that at the baseline, most of the patients, the participants had a similar delirium symptom score. But at the end of analysis, at the end of 72 hours, there's a significant difference between those who received placebo and those who received risperidone and haloperidol. There was also no significant difference between haloperidol and placebo. So in this primary intention to treat analysis between risperidone and placebo, those in the risperidone arm had significantly greater delirium symptom scores that were on average 0.48 units higher than those in the placebo group at the study end. Patients in the haloperidol arm also experienced significantly greater delirium symptoms than in the placebo arm at the study end, which were 0.24 units higher than in the placebo. Participants receiving risperidone also had significantly greater MDAS score per day than those in the placebo arm, with a mean difference of 0.96. The MDAS scores were higher per day in those receiving haloperidol versus placebo, but this was not statistically significant. There was statistically significantly greater mean extrapyramidal side effects in the risperidone versus placebo arms each day and in the haloperidol versus the placebo arms. For those taking risperidone compared with placebo, there were no significant differences in the Richmond agitation sedation scores per day, but there was a significant difference between the scores per day for those receiving haloperidol versus placebo. A greater proportion of participants in the placebo group had a RAS score of 0 at the study end than either in the risperidone or haloperidol group, but this was not significant. 34 patients died during the study period, 9 in the placebo, 9 in the haloperidol group, and 16 in the risperidone group. For overall survival, those patients receiving risperidone were 29% more likely to die versus those receiving placebo with a hazard ratio of 1.29, while those receiving haloperidol were 73% more likely to die with a hazard ratio of 1.73 versus those receiving placebo. The median survival of all participants in the placebo group was 26 days as compared with 17 days for those in risperidone arm and 16 days for those in haloperidol arm. In the post-hoc analysis, those receiving an antipsychotic drug were approximately 1.5 times more likely to die. Midazolam use was significantly lower among those in the placebo arm compared with the risperidone and haloperidol arm combined on each study day. For those who needed the rescue midazolam, the median dosage during the study was 2.5 mg for those receiving placebo, risperidone, and haloperidol. And there was no difference between this median dosage between the arms on any day or overall. So previously done open label studies of antipsychotics in patients with cancer or receiving palliative care have demonstrated that delirium severity is reduced over time. But they have failed to compare that reduction with the natural course of the natural history of delirium resolution by including a placebo arm. So the findings of this adequately powered RCT conflict with those of the 3 prior done RCTs in established delirium. However, these studies had their own shortcomings. This RCT has demonstrated that behavioral, communication, and perceptual symptoms of delirium associated with distress in patients receiving palliative care were greater in those treated with antipsychotic drugs than in those receiving placebo. There were no significant differences in the baseline characteristics between the arms, including the delirium scores and the delirium severity. There was no significant difference in the mean lowest delirium symptom score achieved between the three groups. Better symptom control occurred in patients in the placebo arm without any increased use of rescue midazolam and less dose titration for those in 65 years or younger. Poor overall survival in the haloperidol group compared with those in the placebo group warrants a further study given the association of antipsychotic drugs and premature death in patients with dementia and widespread use of haloperidol. And a possible mechanism for this could include persistent delirium and longer exposure to antipsychotic drugs after the study period. These data suggest that approaches that identify delirium early, treat the underlying precipitants if appropriate, and provide other evidence-based supportive measures provide a better reduction in symptoms of delirium associated with distress. This finding is aligned with those of prior studies that have demonstrated that even in palliative care in patient or hospice settings, delirium is reversible in up to half of the patients. So the strengths of this study are that this is the first adequately powered RCT of delirium treatment that has specifically aimed to assess control of symptoms of delirium that are associated with distress in the patients receiving palliative care. The study reflected populations in palliative care clinical practice and did not exclude participants who had irreversible causes of delirium. It was not possible to determine the proportion of participants deemed to have irreversible delirium because they would inevitably receive the medical intervention within those 72 hours study period. As treatment of underlying precipitants was often ongoing, there is currently no risk prediction model for prospectively classifying patients at delirium diagnosis for probability of recovery. Another strength of this study was systematic measurement of the extrapyramidal adverse effects and other expected adverse effects. The primary outcome was 72 hours, and although the resolution of symptoms of delirium can take up to 5 to 7 days, an intervention for symptom relief with no effect on symptoms, even at 72 hours, is unlikely to be of benefit in this patient population. The dose used in this study was informed by a prior RCT of haloperidol and risperidone that demonstrated a reduction in delirium severity score at 7 days with a mean daily dose of 1.71 mg of haloperidol and 1.02 milligrams of risperidone. Lower doses were used for those 65 years or older based on a recommendation in the intervention product information to use caution for dosing in the older population. The dose used in our setting were conservative compared to doses reported in practice settings and therefore may underestimate the adverse consequences of using antipsychotic drugs to treat delirium in routine practice. So coming to the limitations, use of oral solution was a limitation because absorption would be different possibly. Low dose of oral antipsychotics because the dose which was used for haloperidol here was the one which is used for chemotherapy-induced nausea and vomiting. Certain symptoms which were not distressing for the participants were also accounted for. Imputation was used for the missing data, which could lead to biased results. Also, there was lack of data on the causes of delirium and uncertainty whether the reversible and irreversible causes of delirium were equally distributed amongst these treatment groups. So, coming to the conclusion, antipsychotic drugs should not be added to manage specific symptoms of delirium that are known to be associated with distress in patients receiving palliative care who have mild to moderately severe delirium. Rather, the management should be relied on ensuring systematic screening, given that two-thirds of patients with delirium are not diagnosed on referral to palliative care. We should ensure reversing precipitants of delirium and providing supportive interventions. It is increasingly understood that informed family caregivers are essential and that this trial gave family caregivers information about delirium and its management and plausibly facilitated their better advocacy for care. Again, this is the consort checklist. This study was done in accordance to that. And yeah, that's the end of my presentation. Thank you.
Thank you, Shruti. Thank you, Shruti, for that wonderful presentation. So let me tell you why we chose those two papers before I take questions. So first thing, both are brilliant studies by brilliant authors. The Temen study, you all know. So that started how early palliative care is important. And that had led to change in recommendation by ASCO and NCCN to include care early in the setting. The second one of Mira Agar and David Currow, the very famous personalities from Australia. So what we usually do for delirium is to prescribe antipsychotics. We are a bit hesitant to prescribe benzodiazepine, but yes, antipsychotics are usually being prescribed. And but this study, the first one, adequately powered study with an impeccable study design and assessment criteria, they showed that antipsychotics are not useful. Rather, they are having more adverse effects than effects compared to placebo. Now, this is something which changed the guidelines. So, from the first line recommendations of antipsychotics for delirium, they have gone to places where, like the recommendations for antipsychotics in guidelines now are like, if the patient poses any harm to the patient himself or herself or to other people around them, then to give antipsychotics at the lowest possible doses for the shortest possible time if other interventions do not work. So this is the change which was brought by this paper. But when we critically appraise this paper, it has a lot of shortcomings. So that Shruti has discussed. So any questions?
Anyone has any questions? Query, comments, experience of using haloperidol, risperidone in delirium? So I think everyone has understood, Prasun, that these two, I don't think there are any comments. I can't see any questions.
No,
And
neither can I.
anyone wants to add anything?
Which route is usually preferred for haloperidol?
Thank you very much for that very clear presentation, very nicely presented two important studies. My comment with the first one really has started off many other CTs and trials in early palliative care. I think Tata also did one on feasibility. Regarding this delirium, this particular trial has included mild and moderate delirium. So the evidence coming out is applicable for mild and moderate delirium. In real practice, clinical practice, we do use in severe delirium to control symptoms. We sometimes do have to finally end up using antipsychotics and do find that helpful, especially at end of life, because we want to preserve the dignity, and when it comes to preventing physical restraint, antipsychotics, I think personally do have some role in severe delirium. We don't have evidence this way or that way in severe delirium. So the take home really is in mild moderate, we shouldn't jump into antipsychotics, but focus on non-pharmacological measures and having the right caregivers and getting them involved. But in severe delirium, I think we still need evidence. Thank you.
Thank you, ma'am, for that.
Absolutely, Dr. Jennifer, very important point. Although this is an important trial, which which will prove probably in future is a landmark studies for practice changing, but definitely for severe delirium, we don't have anything right now. So there are few questions. Prasun, can you take up these questions?
Yes, ma'am. Yes, ma'am. Sure. So first question is from Dr. Manish. Which route is usually preferred for haloperidol? So the patients are able to take, we have haloperidol both as injectable as well as oral tablets, which are also mouth disintegrating tablets, which can be given sublingually. So what we usually prefer is a sublingual route if the patient can take, because that will be easy at home. And if the patient is in severe delirium and can't be given oral medications or sublingual medications, then injectable are the ones to use. What is the duration of low dose haloperidol by guidelines? Maximum up to 2 weeks. That is a duration which is recommended by guidelines. We should have more of these sessions and test sessions and go through such papers in a faculty.
So Meenakshi has
Yeah.
some comments, I think.
Yeah, thank you, Meenakshi ma'am, for that.
Dr. Meenakshi,
Comment.
you want to say something?
Ma'am, just wanted to say that we should have more of these sessions because, as a group, we would go through this, and since many senior faculty are attending, they can give their valuable insights to this critical appraisal of papers. Just wanted to say that. I mean, I'm sure you're already planned all this, but more such sessions will be very valuable for our postgraduates and to, new palliative care physicians. Thank you.
Absolutely, Dr. Meenakshi. So next series will be, we will start with all evidence-based lectures, and probably we will keep such papers in between. This was an important class, according to me, to understand by all that these two papers, although first paper everybody knows about this paper, but the way today it has been explained and in detail, I think definitely it was useful. And second paper also gives a insight that we keep using haloperidol and risperidone, whether it is going to be useful in future, it has a big question mark. So I'm very happy, Prasun, and I forgot the name.
Shruti.
What?
Shruti.
Shruti and Prasun. It was such a wonderful 1 hour we have spent, and it was very, very useful for everyone. So thank you very much. And today there is one more question from Archana Vijayala.
Yes, ma'am.
Prasun, what is the recommended
Yes,
dose
ma'am,
of
I got it.
haloperidol?
So-
Yeah, please tell us. Then
Yeah.
tell her. then-
So the recommended dose, they have changed now. So the lowest dose, whichever is needed, is the one which is recommended by guidelines. So that can vary from 0.5 milligram, which can be repeated 2 to 4 hours, to a maximum of 10 milligram per day. So that is the maximum of haloperidol which can be given according to guidelines. And now
Shubha,
that
can I also
we have-
add?
Yes, please go ahead, Shubha.
Sorry, did Prasun finish? I thought he had finished speaking.
Yes, ma'am. Please go ahead.
Yeah, okay. So I just wanted to add two things. One is, of course, wonderful presentation and guidance by Shruti and Prasun. So the one thing is whether we should be having journal clubs interspersed, like Meenakshi was saying. I don't know whether we should be looking at one paper and the methodology and the comparison and limitations, so that PGs actually understand what are the limitations, and they are able to analyze this paper critically. So whether we can have that, that's one. And second, about haloperidol and risperidone. Our practice is to use obviously risperidone in Parkinson's patients when we get referrals. So it's a multi-specialty hospital. We get other patients, other non-malignant patients, and we do get Parkinson's. So our experience is using risperidone in such patients with, of course, Riles too. We don't have injections, so we start with probably 0.5 and see like how the patient responds, and then increase to 1 milligram, either once a day or twice a day. And like Jennifer said, for severe agitation, then we might obviously need to start a continuous infusion of haloperidol, and we've sometimes hiked it up to 10 to 15 ml, very rarely. but otherwise it gets controlled with 5 or 7.5 in a continuous subcutaneous infusion. These are the things I wanted to say. Thank you.
Thank you, Shobha. So we are planning to include general clubs also in this series of lectures. We are just thinking that it should be separate or in continuation on Monday. We'll come out with this, the final information. So thank you everyone, and thank you Shruti and Prasun. It was such a wonderful 1 hour we have spent with you, with so much of information and so much of clarity in thoughts everybody got. This is actually the last lecture of this series, and we will have a special lecture next Monday by Puneet and Dr. Roop Gursharani for a prognostication in neuro-palliative care patients. This will be last lecture from this series, and then we will have 1 week break, and then we will start new series with our new titled Academy of Palliative Medicine from IAPC, and you will find that series again very useful, I'm sure. So please remain in touch, whatever information Archana is sending in regularly. So next week we will see you before 6:30, and then we will again re-inform all these things, whatever I have said today, so that people will remain on track what is happening in terms of academy by IAPC. Thank you very much. Thank you, Prasun, Shruti, once again. Thank you everyone for joining. Thank you, Shobha, Dr. Jennifer, and Meenakshi for your comments. I think when senior people are speaking with authority and with experience, I think it is a good learning for MDs. Thank you everyone for joining, and thank you Archana and Nisha for keeping everything on track. Thanks a lot. We'll see you next week before 6:30.
No, I think Kakasha has raised the hand. Hello, Kakasha?
Yeah, can you hear me? This was just for an open discussion by the experts, how immune check inhibitors can be, a game changer in terms of, you're talking about early palliative care, bringing about changes, and also how it has not affected much in head and neck cancers. But that apart, any views on this?
So immune checkpoint inhibitors in non-small cell lung cancer, I don't think that would make any much difference, because yes, the adverse effects and the patient's concerns are a bit changed because of the new immune-related adverse events which happen. We do get patients which are referred with immune checkpoint inhibitors. So the management line varies a bit, but more or less it works on the same line. So I don't think that there will be much difference.
Can I just add something? I think there was a study conducted at TMH with head and neck patients who were undergoing, I'm not sure if it was chemotherapy or if they were undergoing targeted therapy, but that study actually proved that integration of palliative care along with cancer-directed treatment did not improve outcomes.
Yeah, exactly. In head and neck cancer, it did not improve. So, I mean, that is a different entity altogether. But even in lung cancer, because everywhere, I mean, there's talk of immune check point inhibitors being the game changer these days. So, I mean, what are the finer nuances?
All I can think about is two things. There could be treatment-related toxicities and already the burden of the disease. So I think the treatment toxicity is something that we could control, and symptom management could be taken care of by palliative physicians. So it's a good question, but I think, yeah, we need more research to answer these questions.
Yep, probably, inclusion of a med-on person would, I mean, views from them would, because I think overall, the outcomes and survival has changed drastically with the inclusion of immune checkpoint inhibitors, especially in non-small cell lung cancer. Obviously, in head and neck cancer, it didn't show much improvement.
I think that was one of the limitation also which Kemal has stated that her paper holds true for NSCLC, but we still need to understand if that could be generalizable to other cancers as well.
Yeah.
Okay. Thank you, Prasun sir, and thank you everyone.
Thank you, Shruti.